Good morning, everyone. Our subject today is challenges in interpreting thyroid function tests in the diagnosis of thyroid disease. According to the World Health Organization, approximately 750 million people across the world are suffering from some form of thyroid disorders. Unfortunately, up to 60% of those with thyroid disease are unaware of their conditions and consequently undiagnosed and untreated. From 4 to 20% of adults have subclinical hypothyroidism, particularly in women and older people. Hypothyroidism accounts for 30 to 40% of all thyroid diseases. It's one of the most common endocrine disease, yet one of the most unrecognized, undiagnosed, and misdiagnosed public health problem. Thyroid disease is a hereditary condition and it tends to run in families and commonly affects other members in the families. It's with this background that I'm gonna share with you over the coming presentations the basic knowledge of thyroid dysfunctions and the use of thyroid function test for the diagnosis of thyroid disease and monitoring of response to therapy. This presentation overview, we're gonna talk about overview of thyroid stimulating hormone and its relationship with the thyroid hormone, brief overview of the common thyroid disease, to screen or not to screen for thyroid disease, basic thyroid function test interpretation in straightforward case, let's say the usual pattern, an algorithm for implementation and the interpretation of results of thyroid function test. Is TSH best used in clinical decision making to rule in or rule out thyroid disease with a high degree of confidence? That's say, is TSH a good negative test or a good positive test? The controversy or debate of the upper limit of normal for TSH and should it be lowered or not? The main pitfalls in the measurements and the interpretation of thyroid function tests, limitation of TSH and the causes of abnormally high or abnormally low values in euthyroid subjects, common causes of discordant or discrepant thyroid function test, and then a structured action plan for the investigation of patients with discordant or anomalous thyroid function tests, that's say unusual pattern of thyroid function test, and more importantly, the laboratory monitoring of anti-thyroid treatment and thyroid hormone replacement therapy. What should be done when thyroid function tests do not make sense? Sometimes clinical signs and symptoms do not match up with the lab. And finally, subclinical hypothyroidism and hyperthyroidism. To treat or not to treat. When to suspect thyroid disease? Clinically, symptoms and signs of thyroid disease are often subtle, non-specific, and non-sensitive. Physicians must consider and exclude thyroid dysfunctions much more often than they will establish a diagnosis. If only patients presenting with classic, clearly suggestive symptoms and signs are evaluated, many affected individuals will remain undiagnosed. Accordingly, a high degree of clinical suspicion is required, and laboratory tests are essential to establish a diagnosis. Here are some of signs and symptoms of hypothyroidism and of hyperthyroidism. Abnormal results in certain commonly obtained laboratory tests also suggests hypothyroidism or hyperthyroidism. Finding for these tests are: for hypothyroidism, finding of these tests for hypothyroidism may include hyponatremia, hypercholesterolemia, creatine kinase and lactate dehydrogenase elevations, macrocytic anemia, hyperprolactinemia, and the elevation of pancreatin and uric acids. And for hyperthyroidism, elevation of hepatocellular enzymes, hypercalcemia, and the elevation of alkaline phosphatase. Thank you. To follow in the next presentations.